Hello everyone. I'm going to be recording for you processes and stages of labor and birth. So here we go. Those are your objectives. And before we move on to this, let's talk about the factors that affect labor and delivery. We know there are at least 5 factors and probably many, many more, but these are the ones that we specifically point to and talk about and assess and look at to make this a healthy, wonderful experience for everybody. And we refer to them all the time as the 5 P's. P as in Paul. And that would be the passenger, which obviously is going to be the fetus, but also the placenta. That has to come out too, along with the fetus. A passageway, which is going to be the birth canal. That one's probably an easier one. Powers we're referring to our contractions. And then the position of the mother. What position is she in? Which one is going to promote the best oxygenation for herself and the infant, and for them to have better outcomes? And finally, the psychological response. There have been study after study that women correlate how good the birth experience is with the outcome. So psychologically, how are they prepared? How are they taken care of? Did they have a birth plan that didn't quite work? So again, the progress of labor is critically dependent on the complementary relationship or collaborative response of these 5 factors. And again, the 5 P's: passenger, passageway, powers, position of the mother, and psychological response. So when we talk about the passenger, and that's why I have this slide up here now for fontanelles, very, very important are fontanelles, which would be the anterior, and you can see it on the lower right end of the screen. It's very wide. It's about the size of, well, it's very wide. I don't really know the measurements. However, it's almost looks like a marquee diamond shape, and it's the bigger of the two. That's the anterior. The posterior, which would be posterior, it's behind it. It is, and it's the one to the left here. That's the posterior. So when I teach students how to find the anterior is very easy because it's the bigger of the two. Do not take your hand off your head and just go back, and you'll sink right into the posterior. Posterior is much smaller. It's about the size of a triangle, and probably the pad of your index finger will fit inside. So basically, here you are on the anterior. If you move your fingers down, you're going to go right into that posterior, which is going to be right about here. Here's anterior. You're coming down, and your fingers are going to sink into that. So what are sutures? Those are fontanelles, and there's 2 soft spots. Again, the anterior and the posterior. And so what are sutures? They're membranous joints that unite the cranial bones. So you can kind of see, here's a suture, there's a suture, there's a suture, there's a suture. The cranial bones overlap under the pressure of the powers of labor. They collapse underneath each other. The parietal bones collapse together and sandwich underneath the occipital bone. And you're like, oh my God. Well, when you figure the cervix is tightly closed, it's now going to open to 10 centimeters. And most infants' heads are 32 to 36 centimeters. So there's no way it's going to come out through a 10 centimeter opening, right? It's like you and I trying to walk through the door that's barely cracked open. Not going to happen. And the cervix is the door to the uterus. Anyway, so overlapping is called molding. And so we move on to what is molding. It's a normal phenomenon during which, and here it is, the parietal bones slide under each other and the occipital bone and frontal bones under the parietal bone. So it's almost like a sandwich of these cranial bones. It reduces within 24 hours of birth, and some textbooks even said 48. So when they come out with this molding and this very swollen caput, is what we call it, on their head, that's normal, and you can tell them that. Not to be confused with a hematoma, and we'll talk about that later. Okay, so now we're going to talk about the passenger. Or we're still talking about the passenger, actually. The fetal lie is the long axis of the mother to the long axis of the infant. And so longitudinal, and here we've got the long axis of the mother, that's the pelvis there, and the long axis of the infant is parallel to the mother. So this is longitudinal, this is longitudinal. Transverse is across. It's perpendicular to the mother, so this is transverse. And oblique is like kitty corner. It's going to be, it's not straight. It's not longitudinal up and down like these, even though this one is breech presentation. This is vertex. This one is transverse across. Oblique is where they're going this way or that way. Perpendicular. And you'll also hear the term attitude, which is a relationship of fetal parts to each other. And for the most part, it's flexed the whole time. There is a period of extension as they come out of the birth canal. And we'll talk about that later with the 7 cardinal movements of birth. The presentation is how do they present? That's basically it. The presentation is what part of the body is coming out first? Is it the occiput, which we know the occipital bone is the back of the head, which is what this one is? Is it the mentum, the chin, which here we have a picture right here of the chin, the protruding part of the lower jaw, which would be a very, very, very hard delivery? Or is it breech, which is the sacrum, the butt of some sort? And so speaking of breech, the occiput, this is what we usually want and we strive for. 97% of births come out head first. Mentum, we don't even have a percentage, is very, very rare. Sacrum, only 3% of births. I was so surprised at that because I've been at so many deliveries that were C-section for breech. So let's break down this breech presentation. We have what we call a complete breech, which is buttocks and feet present to the maternal pelvis. So, and this would be a complete breech where they're kind of sitting Indian style. A frank breech, which the buttocks is only presenting. Actually, let me take that back. This one, they would have to be sitting more upright. This actually is the frank breech where the buttocks only is presenting. I don't know that I have a picture of the complete. The complete is where they're sitting in Indian style. So they're probably a smaller baby where the feet and not feet so much, but knees are further down than this one. Buttocks only is presenting with the frank breech. The hips are flexed, knees are extended in the frank breech. And so that's what this one is. Complete is buttocks and feet present to the maternal pelvis where they're sitting Indian style. Actually, this one could be called either one because the legs aren't straight up. I've seen them where the legs are straight up. So let me clarify that for you again. The complete breech is the buttocks and feet present to the maternal pelvis and they're sitting more like Indian style. A frank breech is when it's frankly just the butt. Buttocks only is presenting, the hips are flexed, and the knees are extended, so the legs are straight up in the air. So basically, this is a complete breech. Yeah. Frank is when, again, the knees are extended and the legs are straight up in the air. A footling breech is just that. The foot is coming out first to the maternal pelvis. Single or double footling presentation. Shoulder presentation, usually the fetus is in the transverse lie, which would be this one, where the shoulder presents first. Again, very difficult delivery. So again, talking about the presentation, we've got the mentum would be the jaw, occiput, whether it's the face is presenting posterior or anterior, the head's presenting, and the sacrum is going to be, again, the buttocks. This one right here, this last one listed would be a very difficult delivery in that, look at where the cord is. It's around the body and the neck. This baby, if it was born breech, could be stillborn because of how tight this cord may be, which is going to cut off the oxygen supply. That's why we don't do breech deliveries anymore vaginally. Sometimes they just happen. and hopefully the baby's small enough to get out. But other than that, we don't know where the cord is, so we don't advocate for that anymore. Okay, now this one is we're going to include the passenger and the position together. It's the relationship of the presenting part to the mother's pelvis. Now I know this sounds a little crazy. I'm actually going to go over it in class. I just couldn't do all of it in class. So let's look at this. I'm going to have you look at this one, but it reflects this. Are we talking about the mom's pelvis, the right or left of the pelvis, the presenting part? So first we're going to figure out if they're, in looking at it, are they on the right or the left side of the pelvis? What's presenting? Is it the occiput? Is it the chin, or it's the sacrum? And mom's pelvis, are they facing anterior, posterior, or transverse? So with that in mind, let's do a couple. So here's an example. It's called ROP. So R means, let's go back, the right of the pelvis. And so find the landmark is the occiput, which is the backbone in the head. So the occiput, you see how it's facing the right side of mom's pelvis. So it's right occipital posterior because it's facing the back of the pelvis. This one is the opposite of this one. It's the occiput is facing the left part of the pelvis, and it's posterior because it's in the back. If it's in the front, see here's anterior, it's coming out first. That's anterior. These are both posterior. So the right side of the mom's pelvis, here's the left side of the pelvis. Both occiput here are facing posterior because they're facing the back. So it's right occipital posterior, left occipital posterior. These are the easier ones, the transverse. Well, I don't know how easy it is. To me, they're easier. And so again, the occiput, where is it? It's facing the right side of mom's pelvis. The occiput is, but it's transverse. They're sideways. And this one's the opposite. It's the left side of mommy's pelvis. But it's transverse. And then these two are the opposite of these two up here. We've got the occiput is facing the right side of the pelvis, but it's anterior because the face is in the back. And this one, again, is anterior. Left side of mommy's pelvis, the occiput is, and it's anterior because the occiput is facing forward and the face is facing back. Again, the landmark, if you always find the landmark is the occiput. You're not going to go with the face, you're not going to go with the ears or anything else. You're going to go with the occiput, which is the back side of the head. That's the landmark. Is it the right or left side of mommy's pelvis, anterior or posterior, depending on whether the landmark is in the front, back, or side of the pelvis? The left occipital anterior, this one, is the most common and the most favorable fetal position for birthing, followed by, LOA, followed by ROA. Nobody knows why, and it depends on woman to woman, depending on how roomy the pelvis is, but for whatever reason, we have better outcomes when they're LOA. The left side coming out, maybe it has to do with the bladder in the front, I don't know, but the LOA is the most common and most favorable fetal position for birthing, followed by ROA. Posterior occiput is much harder to deliver, to go under the pubic arch, is the posterior delivery is much harder. There's a lot of room between here and here, that the ears, that sometimes if they look up, the facial bones do not overlap. You notice when we talked about coming out, the bones that overlap are only in the head. Okay, we're going to have to stop right here, and I will be back with the second, third, and fourth part of this presentation.